Finals SAQ80, pre-eclampsia. A 25-year-old woman who is 37 weeks pregnant and known to have pre-eclampsia is admitted to your labor ward with a blood pressure of 160 over 110 mmHg on several readings. A. What is the definition of pre-eclampsia, and which related symptoms should pregnant women be told to report immediately? Based on the ISSHP definition of pre-eclampsia, it is defined as new onset hypertension, systolic BP of 140 mmHg or more, diastolic BP of 90 mmHg or more, or both, accompanied by one or more of the following features at or after 20 weeks gestation: proteinuria, other maternal organ dysfunction such as AKI, liver involvement, neurological complications and hematological complications, and utero-placental dysfunction. Proteinuria is considered positive if 1+ or more, urine protein-creatinine ratio of 30 or more, or albumin-creatinine ratio of 8 mg per millimole or more, or both. Pre-eclampsia can present without proteinuria. AKI, defined as serum creatinine of 90 micromole per liter or more. Liver involvement occurs when there are raised transaminases, or ALT 70 or more, or twice the upper limit of normal range. Examples of neurological complications include eclamptic seizures, severe headache, persistent visual scotomata, clonus, blindness, altered mental status, and stroke. Examples of hematological complications include thrombocytopenia, DIVC, and hemolysis. Utero-placental dysfunction is evidenced by abnormal umbilical artery Doppler waveform analysis, restricted fetal growth, stillbirth, etc. Additional notes: ACOG described pre-eclampsia as being with or without severe features, which includes systolic BP of 160 or more, or diastolic BP 110 or more, thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, new onset headache and visual disturbances. HELP syndrome is defined as hemolysis, elevated liver enzymes, and low platelet syndrome. It is a potentially life-threatening condition to both the mother and baby. Women may be critically unwell at presentation with placental abruption or DIVC. Symptoms to report immediately include severe headaches, visual disturbances, blurred vision or flashing lights, sudden swelling of hands, feet, or face, upper abdominal pain or vomiting. B. How should this patient be managed following admission to your labor ward? Multidisciplinary management is required of this obstetric emergency, involving obstetric, midwifery, and anaesthetic and intensive care input, level 1 care as a minimum. Assess and manage the patient simultaneously following a systems-based approach. Airway assessment, anesthesia for urgent delivery or airway support may be required. Laryngeal edema and difficult intubation are more likely if there is voice change, hoarseness, and facial edema. Respiratory. Assess oxygen saturations, respiratory rate, and auscultate the chest. Pulmonary edema may lead to respiratory failure. Supplemental oxygen if required. Consider fluid restriction, 1 ml per kg per hour to a maximum of 80 ml per hour. The patient may need extra fluid bolus if hydralazine is commenced to avoid hypotension. Cardiovascular. IV cannulation, antihypertensive medication to target BP less than 150 over 100. First line is oral or IV labetalol. Second line, IV hydralazine. Third line, oral nifedipine. Frequent blood pressure checks to monitor response. Neurology. Assess for hyperreflexia, severe headache, and visual disturbances. Above-mentioned features may signify risk of eclampsia. Consider magnesium treatment if these symptoms are present or if there is significant proteinuria. GI. Keep new by mouth and administer an acid as there may be likely imminent delivery and possibility of seizure. Hematology. Check FBC for platelet levels and coagulation screen for coagulopathy. Renal. To assess disease severity, monitor urine output, urine PCR, urine dip for protein and renal function. Hepatic. Check transaminases and bilirubin, assess for HELP syndrome. Obstetric. Continuous fetal monitoring with CTG, especially once antihypertensives are initiated. Uric acid is a marker of disease severity. Plan for delivery. Baby is at term and the ultimate cure for pre-eclampsia is delivery of the placenta. C. What changes would you make to your usual general anesthetic technique for a pregnant woman if this woman needed a GA for caesarean section? A. Airway. Increase awareness of risk of difficult airway. Assess for upper body or facial edema and hoarseness, which may indicate oropharyngeal and laryngeal edema. Prepare for difficult airway according to DAS Guideline 2015. Airway edema may worsen over the duration of surgery. Deflate the ETT to check leak before extubation. Respiratory. Limit fluid input to 80 mL per hour unless matching losses such as hemorrhage. Pulmonary edema may necessitate increased airway pressures and PEEP to provide adequate oxygenation. If pulmonary edema is severe, the patient may require post-op ventilation. Cardiovascular. Consider IABP monitoring. Reduce the pressor response of intubation with short-acting opioid such as alfentanil. Consider short-acting beta blocker such as labetalol for BP control. Manage pressor response of extubation to avoid complications of hypertension such as hemorrhagic stroke. Pharmacology. Caesarean section under GA presents increased risk of uterine atony and PPH. Ergometrin is contraindicated due to its hypertensive effects. Neurology. Ensure adequate pain relief before waking, as increased catecholamines increases blood pressure. Consider tap blocks and morphine. Magnesium prolongs the effects of depolarizing and non-depolarizing muscle relaxants, hence mandatory use of nerve stimulator. Consider neuromuscular blockade reversal with sugammadex if rocuronium is used. Renal. Avoid NSAIDs due to its kidney injuring effects. Comments. 16.1% pass rate. Additional information. Hypertensive disorders in pregnancy. Key points. Target BP during pregnancy is less than 135/85 mmHg. New risk prediction models for pre-eclampsia can help guide decision making. Suitable treatment options for hypertensive emergencies includes labetalol, hydralazine, and nifedipine. Hypertensive disorders during pregnancy are associated with long-term increased risk of cardiovascular diseases. Women should be offered lifelong follow-up. Examples of hypertensive disorders during pregnancy includes chronic pre-existing hypertension, gestational hypertension, and pre-eclampsia. Mortality. According to the Ireland and UK confidential inquiries into maternal deaths, 2017 to 2019, 2% were attributable to pre-eclampsia and eclampsia. Morbidity includes maternal CVS morbidity, stroke, preterm birth, small for gestational age babies, cardiovascular diseases in later life, etc. Definitions. According to ACOG, hypertension in pregnancy is defined as SBP of 140 or more, diastolic blood pressure of 90 mmHg or more, or both, ideally confirmed on 2 occasions at least 4 hours apart. Chronic hypertension is defined as hypertension that presents before 20 weeks gestation. Examples of causes include essential hypertension and secondary causes such as white coat hypertension, intrinsic renal diseases, renal vascular diseases, endocrine diseases such as Cushing's, Conn's, pheochromocytoma, acromegaly, and hyperparathyroidism, coarctation, pregnancy, malignant hypertension, drug-induced such as steroids, MAOI, cocaine, or amphetamine. Gestational hypertension is new-onset hypertension that develops after 20 weeks gestation without any features of pre-eclampsia. The definition of pre-eclampsia has been discussed previously. Risk factors for development of pre-eclampsia. Strong risk factors includes prior pre-eclampsia, chronic hypertension, maternal BMI more than 30, pre-gestational diabetes mellitus, antiphospholipid syndrome or SLE, and assisted reproductive therapies. Moderate risk factors includes primiparity, paternity, advanced maternal age, 40 years or more, family history of PE, multiple gestation, and chronic kidney disease. Risk prediction tools for pre-eclampsia. Placental growth factor, PIGF, is reduced in pre-eclampsia. Soluble FMS like tyrosine kinase 1, SFLT1, is increased in pre-eclampsia. SFLT1 to PIGF ratio is increased in pre-eclampsia. PREPS prediction model for risk of complication in early onset preeclampsia is based on gestational age, vital signs, and biochemical observations. Full Pierce or preeclampsia integrated estimate of risk is based on gestational age, vital signs, and biochemical observations. Prevention of hypertensive disorders in pregnancy. General lifestyle advice such as healthy diet and exercise. Based on the ASPRE trial, it concluded that there was a lower rate of preterm preeclampsia in women taking aspirin 150 mg at night from 11 to 14 weeks to 36 weeks gestation compared with placebo, 1.6 versus 4.3%. NICE guideline recommends that women at high risk of developing preeclampsia should be given aspirin 75 to 150 mg daily from 12 weeks until the birth of the baby. Women with 2 or more moderate risk factors should also be offered aspirin. Regarding calcium, if calcium dietary intake is low, supplementation of 1 gram or more per day may lower the chances of developing preeclampsia. Folic acid. Based on the FACT trial, in high-risk women, high-dose folic acid supplementation 4 mg per day beyond the first trimester does not prevent preeclampsia. Management. Blood pressure. A sustained BP of 140/90 or more warrants treatment, targeting BP of 135 systolic and 85 diastolic mmHg. The main aim of controlling maternal BP is to prevent intracerebral hemorrhage and stroke. Options for treatment includes labetalol, nifedipine, mitadopa, hydralazine, prazosin, bisoprolol, and metoprolol. Avoid these drugs if contraindications are present. Thiazide diuretics, ACE inhibitors, and ARBs are avoided due to risk of congenital abnormalities. Timing of birth. Monitor the mother and fetus with BP monitoring, urinalysis, blood tests, and fetal ultrasound every 2 to 4 weeks. Frequency of monitoring should be adjusted according to clinical picture. Planned birth before 37 weeks should be considered for women with preeclampsia with severe features. After 37 weeks gestation, birth should be initiated for women with preeclampsia within 24 to 48 hours. Hypertensive emergencies. Severe hypertension is defined as 160/110 or more mmHg persisting for more than 15 minutes. In hypertensive urgency, there is absent acute target organ disease. In hypertensive emergency, there is presence of acute target organ disease such as MI, pulmonary edema, respiratory failure, and stroke. Risk factors for hypertensive emergencies includes preeclampsia, chronic renal disease, cardiac disease, non-compliance to antihypertensives, use of uterotonic agents such as ergometrin, use of recreational drugs such as cocaine and amphetamine, low socioeconomic status, and non-Hispanic black population. Investigations for the mother: blood, FBC, creatinine, electrolytes, LDH, fibrinogen, and haptoglobin, urine, PCR, ACR, and microscopy, ECG, and fundoscopy. Specific investigations when indicated: echocardiography to look for ischemia and heart failure, brain imaging for stroke, chest imaging for aortic dissection, renal ultrasound for renal parenchymal disease, urinary drug screen for cocaine or amphetamine, cardiac troponin to identify ischemia, and B-type natriuretic peptide to diagnose heart failure. Fetal investigations includes ultrasound for fetal growth, Doppler flow studies, and cardiotocography. Treatment. Initiate urgently in high dependency setting. Aim for step controlled reduction in blood pressure, which can be treated with labetalol, hydralazine, or oral nifedipine without requiring invasive cardiac monitoring. First line is labetalol. Second line includes hydralazine, nifedipine, GTN, and furosemide. Maintenance fluid should be restricted to 80 ml per hour to avoid the risk of pulmonary edema unless there are ongoing fluid losses. Careful fluid balance monitoring is a must. Third stage of labor should be managed with oxytocin. Avoid ergometrin due to its vasoconstrictive and hypertensive effects. Eclampsia. This is usually self-limiting. Risk for eclampsia includes maternal hypoxia, pulmonary aspiration, and stroke. Prevention is by magnesium sulfate, which is indicated in women with PE presenting with persistent neurological symptoms or signs such as severe intractable headache, signs of cerebral irritability, clonus, and visual disturbances. Initial loading dose is 4 to 6 grams IV over 20 to 30 minutes, followed by continuous infusion of 1 to 2 grams per hour until delivery for 24 hours. It may also be given intramuscularly to gluteal muscle with a loading dose of 10 grams given as 5 grams IM into each buttock, followed by 5 grams every 4 hours. Treatment of eclampsia is by max-half, loading dose and infusion as above, and further 2 to 4 grams boluses for recurrent seizures. NICE guidelines do not recommend the use of benzodiazepines or other standard anticonvulsants as an alternative to magnesium sulfate in eclamptic seizures. Monitoring for toxicity includes blood pressure, urine output, respiratory rate, and patellar tendon reflex. Toxicity signs includes hypotension, oliguria, respiratory depression, hypoxia, and decreased patellar tendon reflex. Therapeutic levels is 2 to 4 millimole per liter. ECG changes such as increased PR and increased QRS occurs at 3 to 5 millimoles per liter. Patellar reflex is lost at 5 millimole per liter. At 7.5 millimole per liter, respiratory depression occurs. At 12 millimole per liter, blood magnesium cardiac arrest occurs. There is increased magnesium toxicity risk in renal failure. According to the MAGPIE trial in 2002, this is an international trial involving 175 hospitals in 33 countries, which recruited 10,141 women with pre-eclampsia, randomized to magnesium sulfate or placebo treatment, concluded that pre-eclamptic patients on magnesium sulfate had 58% lower risk of progressing into eclampsia compared to placebo. There is relative risk reduction of 45% for maternal mortality, no differences in intrauterine or neonatal death. Treatment of magnesium toxicity is by giving calcium gluconate, 10 ml of 10% concentration over 10 minutes IV. This table compares calcium chloride to calcium gluconate. Both are clear solutions and comes in 10%, 1 gram in 10 ml vial. Calcium chloride has 3 times more elemental calcium than calcium gluconate. Osmolality of calcium chloride is 2000 compared to 680 for calcium gluconate. Hence, calcium chloride can only be given via CVL, whereas calcium gluconate can be given by a peripheral IV line. Calcium chloride has higher risk of tissue necrosis if extravasated, unlike calcium gluconate. Other uses of magnesium sulfate includes to blunt adrenergic responses to intubation, as a vasodilator, BP stabilization during pheochromocytoma surgery, antiarrhythmic, analgesic, bronchodilator, for neuroprotection, and as a tocolytic. Other effects of magnesium includes myocardial depression, blockade of catecholamine receptors, antagonization of calcium ions, reducing ACH release at neuromuscular junction, inhibition of platelet function, and potentiation of non-depolarizing neuromuscular blockers. Considerations for anesthesia in hypertensive disorders of pregnancy. Analgesia. Neuraxial analgesia reduces the sympathetic response to labor pain and facilitates CVS stability. However, is contraindicated in coagulopathy and thrombocytopenia. Alternative analgesics includes inhalational analgesia, parenteral analgesia, and PCA remifentanil. Anesthesia. Central neuraxial anesthesia is preferred over GA for most women with preeclampsia if C-section is needed. GA risks airway problems and hypertension during laryngoscopy and extubation, increasing the risk of stroke. Maintain blood pressure at pre-induction values and prevent MAP of more than 110 mmHg or more. Hypertension is treated with IV opioids, labetalol, esmolol, or magnesium sulfate. Hypotension is treated with fluids, phenylephrine or metaraminol. Continue magnesium sulfate infusions to reduce the risk of seizures. If magnesium sulfate is infused, ensure adequate neuromuscular blockade reversal. Airway problems include failed intubation due to edema, mucosal bleeding and pulmonary aspiration. Use of video laryngoscope is recommended. Smaller than expected tracheal tube diameter may also be required. Monitoring. Standard monitoring includes oxygen saturations, ventilatory frequency, heart rate, NIBP, and urine output. Consider IABP and CVP for high-risk patients. Indications for ICU care in pre-eclampsia includes need for respiratory support, including possible intubation, tachypnea, bradycardia or tachycardia, need for additional vasopressor or other CVS support, need for invasive monitoring, abnormal ECG, need for additional IV antihypertensive medications, acid-base or severe electrolyte abnormalities. Follow-up. Postpartum hypertension can persist up to 6 to 8 weeks. Hence, all women should be followed up 6 to 8 weeks after birth. All women who had a hypertensive disorder during pregnancy has increased risk of CVS disease, stroke, diabetes CKD, VTE compared to women who had normotensive pregnancies postnatally. Hence, all of these women should have lifelong follow-up with their general practitioner. These are my references. Thank you.